everybody. I'm Sarah. I'm here, and I'd like to thank everybody for coming today, and I'd also like to thank especially all of our speakers and panelists for being with us. I'm just going to introduce everybody one by one, and as I say and introduce you, you can come and step up and choose whichever microphone you prefer. All right, our first guest panelist is Brad Ray. Dr. Brad Ray is a professor in the School of Public and Environmental Affairs at IU, Purdue University, Indianapolis. Just the microphone. His research focuses on mental health and substance use, particularly where those populations connect with treatment in criminal justice systems. Much of his recent work has focused on overdose prevention and improving problem-solving court outcomes. He has extensive experience working with criminal justice and treatment agencies at the state and local level. Dr. Ray is also director of the Center for Criminal Justice Research, which is part of the IU Public Policy Institute, a collaborative multidisciplinary research institute within SPIA. Thanks so much for being here. Our next guest is Jennifer Buehrle. Dr. Jennifer Buehrle is a registered pharmacist working as a patient care coordinator for Kroger Pharmacy, where she is a resource for pharmacists in stores regarding medication management, immunizations, and other emerging initiatives. She is also an affiliate faculty member with Purdue University College of Pharmacy. Thanks for being here, Jennifer. And our last guest, Dr. Christopher Suelzer. Dr. Suelzer completed his residency in internal medicine at Indiana University and a general medicine fellowship with a focus on addiction medicine. Since graduation, he has worked in both primary care and addictions, including opioid replacement clinics and detox. He's currently Associate Chief of Staff for Primary Care at the Indianapolis VA Medical Center. He's certified with the American Society of Addiction Medicine and is the current president of the Indiana chapter. Thanks so much for being with us, everybody. The first question, I think what would be relevant is just to ask all of you individually how INSPECT kind of intersects with your daily work. And I thought we could start with Dr. Jennifer Buehrle. As a pharmacist, you're the only one with an actual mandate to actually use INSPECT currently, right?
There's not necessarily a mandate to use INSPECT, but as a pharmacist with Kroger, we were part of the pilot for integrating INSPECT into our system. And so even though it's not required, I would say it's something that we widely use. So on a daily basis, all we need to do is when we're checking a prescription for a controlled substance is to click that button and to analyze the data that we're given, to take a look at if the patient appears to be jumping between multiple doctors, multiple pharmacies, what's the total daily dose that they're taking. So INSPECT plays a vital role in us being able to analyze and make appropriate judgment calls.
And Dr. Suelzer, how about you?
I'll put my primary care hat on. So as a primary care provider who treats a lot of chronic pain patients, obviously one of the struggles that was mentioned is, is this patient have a potential addiction issue or at a risk for overdose? And INSPECT is one tool that allows us to help in that determination. So in the primary care practice, obviously, if we're prescribing opioids, then we utilize the INSPECT. One of the hallmarks of addiction is the inability to control the use of the drug, right? And so it's highly likely that if you're prescribing opioids, unless you're prescribing massive amounts, the patient's going to need to find other sources. And so the INSPECT is a tool that allows us to see is that sort of behavior present among this patient. So, and then from my addiction standpoint, or addiction treatment standpoint, once a person is in addiction treatment, relapse is often the nature of the disease. And so the question is the patient doing well from a treatment standpoint? And again, an INSPECT is a tool that allows me to monitor how well they're doing with that.
And Dr. Ray, you have sort of a different experience as a researcher, correct? Have you studied INSPECT, or how much is that part of what your daily work is like?
Based on everything I've heard about INSPECT, I'm glad I don't have to interact with it every day, because I hear a lot of bad things and complaints sometimes. But so no, as a researcher, I've used it as a point of data to look at changes over time. I've linked it with other data sources to look at trends and prescribing patterns amongst individuals who have fatal overdoses in Marion County primarily.
How much data do we actually have about PDMP and Inspect in general's effect on drug use or prescribing patterns? And I guess that would be a question for Dr. Ray, but if anybody else wants to.
Say what was it again?
So basically, PDMPs, what kind of, are there lots of studies or evidence in that they actually affect stuff like opioid deaths or prescribing patterns, that kind of thing?
Well, let me back up and say my dissertation wasn't on PDMPs or anything like that, so my knowledge is somewhat limited of it. But the trends that we're seeing here, and another thing I'll mention just going forward is that I'm a community engaged researcher, so everything I do is pretty much in Indiana or central Indiana. So what we've been seeing here is that there are some links that individuals that die of fatal overdoses and non-fatal overdoses were previously in Inspect. I mean, we see links there, yeah.
Right. I'm going to talk about, I'm curious about dispensers and prescribers. So the Inspect sort of legislation makes a difference between the two. And so, Jennifer, I know we were talking before about a dispenser's responsibility. And so, as a prescriber, you can say, physicians can say, oh no, I don't think you should have this particular prescription. As a pharmacist and just a dispenser in general, what's your power there? Like, can you also turn people down if you see worrisome patterns?
We absolutely can. I would say that the first step is always going to be to contact the prescriber whenever possible, to try to get some background information. So what is the disease state that we're treating? What information do you have on the patient? Is there a reason that we had this significant dose increase, or that the patient appears to be maxing out on their as needed drug month after month? So I would say ideally we're going to contact the prescriber and work with them to get additional information, or to potentially raise that red flag that maybe they're not aware that the patient is maxing out on their as needed dose consistently. So ideally there's going to be collaboration, but if needed, we can say, no, I'm not going to fill this today. That is part of our responsibility as a pharmacist, is to know when to make that judgment call and to be comfortable in doing so.
How often does that happen? And this could be for either Dr. Suelzer or Dr. Buehrle. Does it happen every day? Does it happen every week? How often do you see something and say, oh no, I don't think we should?
In my experience, I'd say maybe once a week. It really depends on that phone call to the physician. If it's a weekend day, I might be more likely because I'm not comfortable with dispensing the medication without consulting with somebody with more information. So maybe once a week, but I think so much can be learned too with talking to the patient and how they respond. I can think of scenarios where if I let the patient know, last month we filled this for a 30-day supply, and that was if you were taking the maximum dose every day, and you're here on day 28, can we please wait till Monday? And depending on their reaction can really give you an indication, and you have to make that call. But I would say probably once a week I would turn something down, or at least say we have to wait.
Mm-hmm. And Dr. Suelzer, I know you said in your position at the VA, you do kind of come into contact more than maybe some other physicians might. How often do you actually turn somebody down for a prescription if they're, based on what you see in Inspect?
I think when Inspect initially rolled out, a lot of us were surprised by the information it provided. So during the initial phases, and it was alluded to earlier, that often, as a physician, you want to trust your patients. That's the foundation of your relationship with them, is based on trust. And obviously with addictions, there's a lot of deception involved. So when Inspect first rolled out, despite the grumblings, many of us looked at it and were somewhat shocked by some of that information. With time, if you have a stable patient population and you've intervened on those who have addiction issues, it becomes less, I wouldn't say useful, but you find less of that. So once you've adopted it and into your practice, I would say the percentage is actually pretty small right now. So, but you're still surprised every once in a while. The interaction between pharmacy and primary care, the pharmacists are obviously a key element of this. And on the other side, how often have I had a pharmacist call me to let me know? Rare, if ever. And it's not pharmacy, often, at least, talking to pharmacists, when they used to try to call physicians, often it's, one, you can't get hold of a physician. I mean, I turned my pager off for this. No one's going to get hold of me. And so getting hold of physicians is a huge barrier. And then when you do get hold of the office, it's like, why are you calling me? And so there's a lot of, I think, intrinsic barriers to that sort of communication. But it does sort of open up the tool, the option is, you know, if I'm going to look in the inspect, that information that the pharmacist might normally try to convey to me could be in there, right? And so now it's not about a pharmacist calling me saying, hey, do you know that this patient just got a prescription a week ago? That should be available to me in my electronic medical record system.
I know Dr. Harley talked about the relationship between a doctor and a patient. And I'm wondering what it's like when you have, what do you say to a person? And sort of related to that, what's your responsibility to them once you say, I can't give you this medication?
That's a great question, too. Because you're right, many of these patients you have long-term relationships with. And in my opinion, anyway, that relationship can be a very important leverage to getting the patient into treatment. Right? These aren't bad people. They're not, you know, out there to lie to you and you know, make you feel bad. These are individuals with a disease. Deception can be part of that. Often they have other issues that need to be addressed. And so I think a caveat with the inspect process is once I have that information, and this is my approach, I hope, is to leverage that to try to get the person into treatment, right? If you really, and we talked about it, if you don't get the person in treatment and I just cut them off, I'm probably just sending them to another supplier. And unfortunately, in this day and age with heroin and fentanyl, it's probably a lethal supplier. So I think that relationship has to be leveraged. The caveat with inspect, and I've seen it, is that prescribers will suddenly see that they quote been deceived or the person is getting, and I don't know if it's a personal issue or what, but I'm going to cut you off and don't come back, right? Which really is, I think, something that we need to really work on. You know, and that's part of the our philosophy towards addiction and treating people with addictions. So, you know, I said if I found out I was giving potassium, which is sort of a potentially lethal drug, and someone called me and said, hey, do you know they're getting potassium from 3 other sources? The first thing I would do would be call them and say, get your tail in my office. I want to talk to you about this, and not, oh, you're getting narcotics from somewhere else. You're cut off, and by the way, our relationship is over.
Mm-hmm.
I think part of how medical professionals are going to respond are going to be based on the opportunities, the places that they do have to send somebody. So when there are so few treatment options, and you're sending somebody out the door that is not going to get into treatment for a month, sometimes more, I think that the way that doctors make these decisions based on it is within that sort of local or state context as well. So what they're likely to do with that information. So having treatment as an option, but also, we have very progressive ideas in this room about medication-assisted treatment, and a lot of medical professionals don't. So I think educating them about that is a pretty important task too.
I'm wondering if, so you can tell a person, hey, I'm worried about you, you need treatment, but how often does that actually result in somebody actually going to treatment and saying, oh, I guess you're right? Like, is that something that you actually see, or is there any kind of connection that you've
that's going to
witnessed?
depend on how hard it is for that person too, right? So if you say go to treatment and you say good luck finding it, good luck waiting, you don't have a car to get there, we don't have public transportation, doctors don't have the ability to give bus passes. There's a lot of barriers of why an individual, even if a doctor told them, still would not follow up with treatment. So it's not just as easy as the doctor saying, hey, you need treatment, you should go there this afternoon. There's a lot of barriers for the individuals on the way too.
Mm-hmm. Another criticism of drug monitoring systems in general is something that has been brought up already today, and the danger that if somebody cuts off prescription opioids, there's a potential that a person might go, and it's easy to find heroin in Indiana. It's easy, and we've seen fentanyl happening. And so is there a worry that the more people use PDMPs, the more people might be turning to more dangerous drugs, or is that a completely unreasonable assumption? Anybody?
I was at a symposium in Bloomington a little bit ago, and I had a nurse come up to me and say just this, that she had suspected, she wasn't from that area, but she had suspected a doctor in her area was overprescribing and worried that if I were to cut this individual off, they're just going to go find heroin. So, I mean, these are real worries that people have. And until we do have better treatment options and we can reduce the barriers for individuals getting into treatment, I know it's not the be-all, end-all fix, but naloxone is there. And that is an option that medical providers could have to prescribe to individuals or provide it to them or tell them where to get that, at least to keep them alive long enough until they can get into treatment.
Sort of changing direction. So right now, the information that's contained within Inspect is somewhat narrow. It's just a prescription history. What potential capabilities could you use an interconnected system like this for in the future? Like, what might you as dispensers or prescribers like to see more in Inspect, or what kind of data might be useful to you?
Information is power, right? And it certainly is important as far as decision making and turning it or looking at the Inspect as helping in decision making by granting that information. So as a prescriber, if I saw that this person was in the emergency room 2 weeks ago and had overdosed, oh my gosh, how powerful would that be? Or what is their risk for opioid overdose? So we just talked about, one of the barriers for prescribers is, well, if I do identify it, I don't know what the best treatment options are. Well, what if the Inspect had a list of the closest treatment options available? I think the potential as providing information to assist the patient in making my decisions, it would be immense.
Mm-hmm.
One thing that I think would be helpful would be for naloxone to be included in the registry, whether it was dispensed to the patient or not, or given to them as a prescription, which I realize there's a lot of barriers to that actually happening. But that would be helpful from a safety standpoint. If an elderly woman has, a high dose of pain medications at home, I would want to know that she has that kit on hand just in case. But also from the other side, if it's somebody who's chronically overusing and being administered naloxone, that would be helpful information to see.
Mm-hmm.
And this, what Chris showed at the end there, I mean, that's just awesome. To have something like that in Inspect, I think would be pretty incredible. But also, doctors have to look through this information and make decisions. And I think the more that we think about setting up a system where there's just flags. I mean, if somebody's been prescribed benzodiazepines and opiates that week and they're in your office looking for opiates again, doctors are busy, they have to go through a lot of stuff. I mean, just make the screen turn red and flash and say, if you cannot get this person in treatment, then provide them with naloxone, all right, or have a conversation with them. So, I mean, looking through the information, I can understand when you're in a rush doing that. We can set this up to have flags in it, and we can integrate other data into it. So if somebody has had a non-fatal overdose, that can be something that a medical provider could see in the past and then make decisions around that.
I'm wondering about Jennifer or Dr. Buehrle talked about barriers, and that's what I'm thinking about. Are there any problems with privacy when it comes to integrating that kind of data into the system? What are you allowed to share, and could you legally put an overdose data or criminal data into an Inspect system? Anybody?
Well, they are putting some criminal data in there now, as I think they call them alerts. I saw it demoed a couple weeks ago, but those are called into the office sometimes, so somebody stole a pad, something like that. So they can integrate that kind of data in there. I just don't think it's happening right now. But also the data that's in there, they can use to generate flags as well. So, having these sort of toxic cocktails, once those are prescribed, a flag could pop up and say, hey, you might want to look into this.
Mm-hmm. And speaking of integration, I know that we're kind of within that process of integrating Inspect into health records. How has that been like for? And I know Kroger has been integrating it. I don't know. Dr. Suelzer, have you seen integration into your EHRs yet?
We are not integrated with other facilities, outside other VA hospitals. We have, within our own system, tried to pull in pieces of information, so to make the inspect more user-friendly in our electronic medical record. We've created a note title that connects directly to the web page. You don't have to Google it, and then downloads that information into our progress note. And so it's easier. It's much easier than having to log in through Google. But as far as communicating with other systems outside the VA system or Department of Defense, no, we don't do that yet.
I would say just going back to what the question was about, how does this make a difference? Before we had this integrated into the health record, I may not have Googled it, but it takes a while to log in. There's multiple steps. You have to indicate which state's data you wanted to pull. So it did take quite a while, and now that it's part of our electronic system, it's one click, it downloads the information and presents it to you. And I'd say, there used to be people where I'd probably look at their profile and make the judgment call that I trusted them. They appear to come to me all the time, whereas now, because it's one click away, I would still check. It is absolutely in the patient's best interest, it's in my best interest to take that step, and having that barrier removed helped. And with our last speaker, I know we were talking a little bit about how to make this data easier to present, and you were talking about red flags. I think that's going to be key moving forward. Integration is just one step, but anything that can help me visualize in an instant that this person is at risk or that there's overlapping between these prescriptions would be invaluable in making those judgment calls.
Mm-hmm. Mm-hmm. I'm wondering, and it's sort of going off of a discussion that Dr. Ray and I had, so INSPECT focuses on the bottom of the funnel. It looks directly at someone who might be abusing opioids. And it was originally used as criminal justice thing. Are we focusing our attention on the right part of this problem, and with always the understanding that a PDMP is only one piece of a larger puzzle?
It is one piece. So, and as Mr. McClellan pointed out, there's a lot of different issues here. So what we do, one of the studies we have going, Dr. Watson and I, we link up when folks die of a fatal drug overdose. We look to see whether or not they were in INSPECT. We can only look back a limited amount of time in this, but we're seeing a lot of folks aren't. This idea that people went from opiates to illicit opiates, from prescription opiates to illicit opiates. We're not seeing that as much. Folks are going straight to fentanyl. So when we talk about this opioid epidemic, it has largely been fueled by illicit opiates, not just prescription substances. And in terms of how it's being used by criminal justice professionals, so this is one thing we look at every year. We do a focus group, and it's always a little bit troubling to me to see how little it is used. It's primarily used where when you pick up an offender, they interact with an offender, they'll look and see, did they have this pill in, did they have it in INSPECT? And then they can make prosecutorial decisions and arrest decisions. But really, in any county, the sheriff there, the criminal justice folks there should be able to say, who's our top prescriber? Like, where are they? How much are they prescribing? And I don't think that this necessarily means you need to go knock down somebody's door and arrest them. That doesn't necessarily mean they're pill mill. They might just need to know that there are other alternatives, that they are prescribing a lot. The police might just need to know where that prescriber is. But the data has not really, to my knowledge, been used much to identify prescriber or dispenser issues as much as it has been focusing on individual users. And that is just a problem. That is a real problem.
Anyone else?
Well, I'll say this. Certainly as a prescriber, when someone deals with addictions, I can see that. And this is sort of touches a little bit on the ethical issues, perhaps. I think we're all taught that patient medical records or patient treatment is confidential, right? And it's really that, I want to say what happens in the office stays in the office, right? It's about medical care. And so now we're exploring the option of that information being used for legal purposes, right? And so I don't have the answers. It makes me a little nervous I certainly think that it should be used for, and I believe it's approved for ongoing investigations. It's a data source. I also believe, you can correct me, it can't be used as evidence. But then and I'm not saying we should or shouldn't, but to open the door of this tool to then start to look at the legal aspects needs to be very carefully thought out. And as far as the reporting to, who does the information get reported to? Who should have the authority to look at this information? So just some caveats, and I'm sure the state is considering that. I currently not sure what the state does with the information, and when I log in, it says it's potentially can be used for this. So.
Yeah, and that kind of leads into the next question that I had, which was, how could we potentially utilize this INSPECT data for public health purposes? It seems like it could be an untapped resource to have all of this data somewhere. Anyone?
Yeah, so I think one public health resource could just be educating some medical professionals. So I mean, again, the folks here are very progressive in this area, but when Aaron's Law first passed and people were allowed to get naloxone, I still do this actually, my wife hates it, but I'll just stop at a random CVS on a car trip and say, hey, can I get some naloxone? And I'll listen to the reasons why I can't. And so we do need to just educate medical providers about INSPECT, about overprescribing, their potential role in that, because I think sometimes they just might not know. So if INSPECT were to say this doctor in this county tends to be above the 2 standard deviations above the mean or something, we would go there and just say, hey, here's a letter. Here's maybe some continuing education that you might get involved in, something like that. So I think that that's one public health outcome that it can have, and the other one is using it as a means, as we said, to sort of set up flags to help divert people away from death. So I think that's the other big public health intervention for it.
Several experts have advocated for mandatory checks of INSPECT before any kind of prescribing. That's currently not the case in Indiana. How important, in anyone's opinion, is a mandatory check of INSPECT, and how difficult at this present time would that kind of law be?
I think mandated use of the INSPECTs is one of the recommendations by many bodies. I support it. Even though it's not state law, I believe my medical licensing board requires the use of the INSPECT at least yearly. Mm-hmm. And I'm somewhat shocked. I don't know what the latest statistics are, but I think, that 60%, I don't know if it's 50% of prescribers are using it, but the fact is it should be 100%. So I think the devil is in the details. If it is mandated, what would that look like? And then perhaps more importantly from an end user, how often would that be required, right? We talked about the barriers to using it, and it does sound great, but as Dr. Buehrle mentioned, when you're in a busy primary care practice, thinking you're going to pull up and inspect every time a patient comes in is really a huge challenge. So yes, I think it should be mandated. I think one needs to look at how often. The use of office staff to do that, set up as surrogates, is very, very helpful. I don't see providers doing this, quite honestly. But yes, to answer your question, I think unless you mandate it, you're going to have a struggle.
Mm-hmm.
I would just say that, as we move forward with the integration piece, the easier we can make the data to use, I think the more that law would mean, because if we can make it easier, we know that they're not just checking it and moving forward. We're giving them data in a format that makes it easy to make that decision.
I was wondering about, I think they're called delegates, correct? That you can they can be like your emissary to inspect. How often do either you, Dr. Buehrle, or Dr. Suelzer, how often do you utilize that kind of assistance, and how important is it?
It's critical. I mean, we have 45 plus primary care providers in our system, and I think almost all of them use delegates. Again, it's really hard to overemphasize how time constraint a provider can be, and even with the best intentions, it's hard to, for whatever reasons, the internet is not connected, or there are just multiple barriers. And so having the ability to delegate somebody, and then you can proactively, many of our providers, it's quite easy now to generate a list of all your patients who are on opioids. Okay, so on a Friday afternoon, we're going to go through and have them reviewed. So I think unless you have the ability to delegate, you're even up it's much harder.
In a couple minutes, we will be opening the floor up to questions. There are microphones on either side of the room, and so if you have any questions for our panelists, you can make your way over to a microphone, and we can maybe just go back and forth depending on how many people want to ask a question. But in the meantime, I just ask you, I know we kind of went over how you thought that Inspect could be improved, but I was just wondering if you had any closing thoughts before we open up the floor that maybe I hadn't asked about.
I guess I'll go first. You know, the topic of the discussion is Inspect, and I think, again, it is a very useful tool. I think the potential is enormous. I think we're still in a very early utilization of it. We do have to overcome the barriers to the busy primary care prescriber on how to integrate it into the electronic medical record. But you know, despite the usefulness of this tool, I will say that it really is a small component into this opioid epidemic solution. It's identified patients, but until we figure a way of changing the way providers address addiction, until we increase access to a treatment, this tool will not be the solution by any means.
Yeah, I think in terms of a closing comment, I'd say one of the bigger, more important things that we can all do is to figure out how to reduce the amount of stigma around this. I mean, I think that's a very important barrier. People have been saying it for decades now, but having some actions to really start to educate not just professionals, but just people throughout the entire state that this is not, these are again not bad people. These are people with an illness, and so to sort of get people to look at it like that, I think would be really helpful in this state. So,
Dr. Buehrle?
This is going back to something that was said earlier. I think an increase in collaboration even between prescribers and dispensers, so the pharmacist and the physician, would be helpful as well. So knowing that, you know, we do see some red flags and we want additional information and being open to that communication. So it's not really part of the Inspect discussion, but I do think it's a key part as we move forward, you know, in trying to resolve the epidemic.
All right, I think we can move on to questions now, and we have one person. Hi, go ahead.
Hi, thank you. I'm Joan Dooley. I work at the State Department of Health, and I was co-chair of the first Attorney General's opioid task force, and actually had the pleasure of helping to write the chronic pain prescribing rules for the state of Indiana. One of the things that I will mention in regard to PDMPs is, yeah, it's clear that use of PDMPs does decrease overall opioid prescribing. But as many of the panelists have mentioned, and thank you for an excellent panel discussion, it's one tool. And I'll never forget one of the primary care docs who was working with us on writing these rules didn't believe that, you know, he knew his patients and nobody in his practice would be misusing opioids. So he decided that in addition to using Inspect, he was going to use urine drug monitoring. And what he found was a significant portion of his chronic pain patients who were never going to multiple pharmacies, never calling in early for prescription refills, who were using opioids exactly as directed, tested urine negative for those opioids. So they were diverting the opioids. So just to point out that it's one tool, but it's not it might be necessary, but it's not sufficient when we're monitoring patient populations. And that brings up, I think, Brad, you said that the overdose fatalities were not in INSPECT. That doesn't preclude that those folks were using prescription opioids. It could be that those opioids were just not prescribed to that person, but they were diverted. Anyway, that's just one of the things I wanted to bring up. And again, thank you very much for a really interesting panel.
Oh, and diverting, Ms. Dooley, do you mean they were selling them to someone else or giving them to someone else, correct?
Yes,
For people who
yes.
don't speak public health in the room.
Yeah, and the CDC actually has data that shows that the majority of opioids on the street were actually obtained by one person from a doctor and then distributed to friends or family. So friends or family who are misusing, even if they didn't get it from one doctor, got it from somebody else who got it from one doctor.
Yeah, thanks, Joan. Just to follow up on that, so we do a study here. It's pretty interesting. I'm sure Joan's probably heard about it, and some of Dennis is sick of hearing about it. But we actually get these toxicology reports on every single person that dies of these fatal overdoses, so we can actually look to see whether or not the substance that they died within their system was prescribed to them. And that very rarely happens. Very rarely is somebody dying from something that was prescribed to them, but very often do they have prescription drugs in their system, as you're pointing out, and they don't have a prescription for it. So yeah, we're able to look at that, and we're trying to do some stuff where we look at trends over time with those linkages.
Thank you for your question. Now to the other side of the room, sir. What's your question?
Good morning. My question is related to acute pain and chronic pain. And has there been a growth in that type of pain in our communities? And if so, what are the root causes of those types of growth?
Okay, I guess I'll answer that. I don't know that the evidence that there's been, quote, growth of chronic pain. I don't know if our society is any different, from 100 years ago when there was a lot of manual labor and so forth. I think there's definitely been growth in the perception that the solution to chronic pain is opioids, and so both among patients and prescribers, right? And so that's part of the dilemma, or part of the reason I think we're in this issue. So I think certainly chronic pain has been with us for a long time, and across all societies and all countries, right? But I think the expectations on how that is managed was significantly altered here.
And I know that Dr. Harley, I think, touched a little bit on how pain wasn't considered a vital sign, and now a lot of people consider pain the fifth vital sign. I don't know if any were, and if Dr. Suelzer, if you were there for kind of that transition into seeing pain in a more serious and alarming way.
This is sort of my bias, yes, and I'm old enough to remember the initiation of the fifth vital sign. And a lot of people attribute that as like the triggering event. I really don't think it was. I think it was part of that. Their overall, historically, we undertreated cancer pain, right, in the 60s and 70s, and there was greater awareness that we need to properly treat that with opioids, right? And then there was this paradigm shift or philosophical shift that, well, if we're undertreating cancer pain, we're probably undertreating chronic pain. And chronic pain is very common. I don't know if it's increased, but I would guesstimate that, at least 20% of my patients come in with pain issues, right? And so there's this philosophical shift where if we're undertreating acute or cancer pain by not using opioids, we're probably undertreating chronic pain, and opioids were safe to prescribe, right? And that was probably the true error in all of this. And so that opened the door, and then I don't know if JACO jumped on board and added to that by saying, we also need to monitor those pain levels. But I don't think people prescribed opioids because the pain score was 7. I think they prescribed it because they believed that opioids would be effective in that pain.
I have a question. Is there any potential that sort of a opioid crackdown on prescription opioid prescribing leaves people in too much pain. And is that something that's on anybody's mind right now as a healthcare professional?
I think it's on a lot of people's mind. I think there was mentioned, 2 million people are on opioids, prescription opioids, right? And I do believe we have to be careful not to, I don't want to use the phrase "throw the baby out with the bathwater," but the reality is the statistics would show that when opioids are prescribed, it varies, but up to 20, maybe 30% of people will go on to develop an addiction or a misuse disorder. But that still means that a large number do not, right? And then the real struggle in the community, the pain treatment communities, even though opioids are always the last option for chronic pain, the reality is they are an option, right? And so there are clearly patients, I think, that benefit from opioids in their chronic pain management. So we have to be very careful not to, in my opinion anyway, come to the conclusion that opioids should never be used, and if you're on opioids, the goal is to get you off if they're benefiting you and there's no evidence of addiction. Now, there are people who have philosophically are very, opposed to that stand. But yes, I think there is a huge potential for patients with chronic pain legitimately who demonstrate no addiction and who are benefiting from pain relief and functionality for getting hurt in this process.
Oh, sure, of course. Sure, Dr. McClellan. Or Mr. McClellan, excuse me.
I'm just kidding. I agree with you. I've met with people. I had lunch with a lady not too long ago who has been on opioids for chronic pain for quite some time, and she's functioning very well. And she's scared to death that she's not going to be able to continue to get them. I said, look, our law is written in a way that she should not have a problem. And so far she has not in Indiana. She, fortunately or unfortunately, I guess depending on how you look at it, she spends part of the year in Florida and has a lot of difficulty getting what she needs there. And that's not the purpose of this. That's, we recognize that there are a lot of people who have been on these medications for quite some time and are functioning well. We don't want to hurt them. And there's a provision in the law that should enable them to continue to get what they need. But we don't want that to be the first option going forward. And let's reduce that going forward as much as we possibly can. And that's why the governor's 2018 agenda is calling for eventually for a mandatory checkup inspect for the first prescription, and also why we've limited, or the General Assembly limited the first-time prescription even now to 7 days for adults.
Thank you very much.
I have a question, and I don't know if anybody would be able to address it, but I'm Joanne Martin, and I've worked in different settings. But what is the role of the payer, whether it's Medicare, Medicaid, or private insurance, in monitoring the use of opioids in prescribing and paying for them?
Since I work in the federal system, most of our patients don't go through their payers, but even so, and this is very anecdotal, every once in a while I'll get letters from insurance companies saying that, did you know that your patient was, and it's not about opioids usually, it's about other medications. And so there is apparently some ability for insurers to monitor this and let providers know of patients who are on dangerous drug combinations.
So something that I've recently started to see an increase of is the number of times that an insurance will not cover a pain medicine, even just the 7 days, without a prior authorization. And when I call, I learn that it's because they are starting to set thresholds of they can only have 3 prescriptions within a 3-month period, but then if you do the 7-day fill, that's 1 prescription. Now we're doing a 30-day, and now the patient's out. So it's really interesting to me because, I mean, I don't have a good answer. I don't know what the role is, right or wrong, but they are starting to play a role, and they're starting to place these limits, and it's just adding to the complexity of the scenario. Because I know a few weeks ago I ran into that. Somebody did the 7-day, followed by 30, followed by 30, came in for that next, and there was no even prior authorization that the insurance would allow. So then, you know, the fear is they're either going to be untreated, they're going to look elsewhere. You know, what can they afford and what are their options? So it's definitely adding to the complexity, but I do think that, like anything else, those restrictions are being put in place with, you know, positive intents. The intent is to restrict the number of pills left at home and to try to encourage patients to take less than what they might need. But it's going to be a while before I think we smoothly transition, and I think it's going to add some mud to the water for a while.
I can speak. I am from one of the payers. I'm a director of pharmacy for one of the Medicaid MCEs in the state. I would say 50% of my job is actually looking at data and looking at prescribing across all acute and chronic uses of medication. We have been working with FSSA around looking at high MED members, prescribers, what we can do. So we collaborate with all of the MCs and the pharmacy directors. Medicaid itself, along with what we were talking, I think it was Senate Enroll Act 226, Medicaid actually has a rule around prescribing of opioids that we are required to implement the 4 MCEs. So I think that adds to the complexity. You have commercial insurers who are putting in limits where it totals the amount of morphine equivalents as the prescriptions are coming through and processing. You have Medicaid. So you have all of these different payers that are implementing different things, although they're very similar, but there's, you know, little intricacies behind that. But I would say the payers want to be part of the solution and want to work with the pharmacists and the prescribers and the researchers to provide as much data forward to see how we can help. And I do think when you brought up the fear, you know, part of what I'm doing when I'm looking at the data is we want to make sure our members, our patients who have legitimate pain continue to be treated, and that is something we're very mindful of.
Any other questions?
Yeah, I will. Thank you. Hi. So again, another sort of comment than a question, and I think that, you know, we're talking an awful lot about opioids and prescribing, and that's why we're here, but we're not talking nearly enough about how else we might manage patients with chronic pain. Somebody asked the question about do we have increased rates of chronic pain, and the data shows no. There's been no increase in reports of chronic pain throughout this epidemic. What we do know is that Indiana prescribers prescribe twice as many opioids as prescribers in the state of Hawaii, and nearly twice as many as in the state of Minnesota, with no differences in pain. So clearly the opioids aren't making a difference in patient reports of pain, because opioids don't get you to zero pain, despite the desire, I think, of many of us to never have pain. I think, as Dr. Harley mentioned, we really need to go back to the roots of pain. Biopsychosocial pain is experienced in your brain, and we all experience pain differently. So one person getting discharged from a hospital after a C-section might not ever need an opioid, and another person might. So it becomes very, very difficult then to have a cookbook formula for who needs opioids and who doesn't need opioids. But what we really don't do enough of, and this could be, I'm a primary care provider by training, this could be as a result of the limited amount of time that we have to actually treat patients, and the limited amount of reimbursement by payers for alternative modalities. So spinal cord stimulators, if you send somebody to a pain management physician, rather than opioids, a spinal cord stimulator could be, if it's covered by insurance, substituted and works beautifully and can get folks off opioids with better outcomes, better functionality. I've heard patients say walking, simply walking 5 miles a day, getting exercise. We know that people who sit on the couch because they're in pain are less likely to get out and exercise, but encouraging them to be active actually decreases pain and increases functionality. So patients have told me that I walk 5 miles every day and that controls my pain. Wow, that's free. Doesn't have any side effects. It doesn't lead to addiction, but we don't focus enough on acupuncture, physical therapy, occupational therapy, but perhaps counseling. People who are depressed have more pain. Using antidepressants to actually address pain. So I would really like to see, and I would be really interested in the opinion of our panelists, an expanded discussion of how to get to functionality that really minimizes focus on opioids. We know National Safety Council has data that shows the number of patients needed to treat with Tylenol and Advil to get pain relief to the same level as using opioids is many fewer. You need to treat many more patients with opioids to get to the same level of pain relief that you do with Tylenol and Advil. Why aren't we prescribing Tylenol and Advil? Cheaper, more effective, fewer side effects, and less, of course, you have to screen your patients. That's medicine. That's not really an algorithm. So anyway, just interested in your thoughts.
I fully agree. And I think you bring up a point which it's just not about opioids. There's a whole list of medical situations like this, and I don't really want to be hypercritical of MDs. I don't have to do that work. It's a difficult job. But, you think about, I have friends that get on, cholesterol medications, and they want to address it first through diet and exercise before they start using this, and sometimes their medical provider doesn't suggest that to them. And so, it's like a whole host of things that we could come up with examples where they should probably be using some of these alternative modalities that oftentimes insurance doesn't cover sometimes too, right? That's part of it.
No, I would agree 110%. So, we talk about access to addiction treatment, and that, the horse is out of the barn at that point, right? And so the question you raise is, how do we prevent even this from starting? And it's so much shocking. The statistic, I think that was mentioned, 24% of Hoosiers have received an opioid prescription. That's just shocking. And the question is anyone looking at, I'm sure there's data on new prescribing, but, have we seen a decrease in new prescribing? And as you brought up, one solution to that, the only solution perhaps is, all the guidelines on chronic pain management now say that opioids are the last option, right? And use all these other modalities that we know are evidence-based and effective, right? But the challenge, and I think it was mentioned, there aren't enough pain specialists in the entire state. And so if I'm in a small town in Indiana and I have someone with chronic pain, how do I get them to alternative treatments? How do I get them to physical therapy or acupuncture or whatever the options are, right? And so just as we need to build a treatment system, we need to build a chronic pain system. And that, I'll turn that over to the state because that's another challenge, right? And so that is a challenge for primary care providers. But unless we have changed, our philosophy toward management of chronic pain and have those options available for our patients, you're going to see prescribers continue to rely, unfortunately, on opioids.
Go ahead.
Follow-up question. Read an article a few months back where I believe the city of Minneapolis and some other cities around the country are taking the pharmaceutical industry to court for fundamentally being responsible for this crisis. And I'm curious from the panel, what are your thoughts about that as part of the at least resource-based solution to addressing this? But also it seems to me that, particularly after the primary care person there spoke, that a lot of this is tied to a market-based approach to addressing health issues in our country, where medicine, opiates in this case, serve to make a lot of folks wealthy. And then that process then influences the care providers in reference, is this the right solution? So I'm just curious, panelists have any thoughts about that idea?
That's a big question. So in terms of the lawsuit, I have heard some stuff about that, and at first I thought that it wouldn't be that, I didn't really know how effective it would be in sort of the current epidemic, but in some of the recent discussions I've had, they're really looking at what has the cost been to citizens in the states and the counties where they're filing these. So for example, how much more naloxone are we using? How many more toxicology reports are we running? And who should that cost be paid, who should have to compensate us for that? And I don't have a problem with it being pharmaceutical companies personally. So if it pans out, I think it'd be great if we could get state resources through that direction. So yeah.
I think we're all culpable in this situation, and I will, say the pharmaceutical industry was also part of that. The fact that there were opioid prescriptions and doses of 180 milligrams a pill, 18 Vicodin for, a one-time dose, just doesn't make sense, So, those days luckily are over at those doses, but I'm just saying there should have been, I think, more thought about these preparations and the doses that were being prescribed by all parties. I'm not putting the blame on the pharmaceutical industry, but they definitely were part of the problem.
Any other questions? Oh, thank you.
So my question is more related to the role of substance abuse treatment providers and how their integration or input would be received from prescribers and pharmaceutical representatives in INSPECT and how that would look. For instance, I oversee quite a few substance abuse treatment programs, intensive outpatient, traditional outpatient, et cetera. And what I'm seeing is I have a high volume of clients that will not sign releases of information for me to contact their primary care physician. However, they're having screens that are positive for high doses of opioid pain medication, benzodiazepines, and I don't have a way to report that. And yet they're in treatment for a multitude of reasons and wanting to be in treatment. So how can we open those communication lines?
I think it's another piece of data that you're suggesting we could integrate into the PDMPs, right? I don't know if work's going on. I know that there's some discussion through the MPH that Mr. McClellan brought up to integrate data, but I don't know if it'll be to that level, at the individual level. But yeah, I think it's a possibility to see if that could be integrated in. I don't know that it's being done though.
I'm making another note.
Oh.
It's actually federal law that so you need to have consent.
I know.
They share that information, but they're looking at what to do about this law at the federal level that's currently being discussed.
Yeah, that has always been a barrier. And the intent of the law was to get people into treatment, right? And so if patients felt that they went into addiction treatment and other entities knew about it, it's going to influence their employment or even the way they're treated, right? And so the initial intent, I think, was to help people get in treatment, but it cuts both ways now. And so so part of the issue will be communication. How do, given the current laws, how can people who are enrolled in addiction treatment, I wouldn't say be mandated, but get that communication to the prescriber? But it also works the other way, right? When a prescriber starts opioids, part of the requirements are to sign an opioid consent, if you would, and in that is, the potential that I will release information if I'm involved in treatment or have other providers, et cetera. So I think you can get that consent at both ends. But you're right, that it's frustrating, I think, when you have patients who are addiction treatment and you know that they're not doing well or continue to use opioids and you can't get hold of the prescriber. But at the addiction treatment level too, you can say that you really need to do this, and depending on your leverage with the patient, you can say that's part of your treatment, is to be open in your communications.
Dr. Harley?
Sure. So I want to comment on a couple of things that have come up in the last several comments. So first, I'm in complete agreement with Joan and Dr. Suelzer around chronic pain, in particular, chronic pain care. There's no good evidence that opioids work for chronic pain over the long term, right? Opioids are fantastic for acute pain and important tools in a clinician's kind of toolbox. But when pain is chronic, there's no good evidence that it works. Am I suggesting here that we should say nobody gets opioids longer than 3 months? No. But certainly chronic pain needs other treatment modalities. And it's incredible as we put an audio recorder in the exam room between a doctor and patient in our research, and as we interview doctors and we see patients with chronic pain who just kind of bounce back every few months, and there's these sort of fragmented, quick conversations around, I'm looking at my note here, I think we said something about a consult with the surgeon, and did you ever go to PT? We talked about that, right? Oh, yeah, you didn't go, or you weren't able to go, and this is not, I'm not putting that on the patient, right? There's lots of systematic reasons why someone doesn't end up there, access challenges and transportation and other social things. But these conversations, they just kind of kick the can down the road, and then the opioid gets refilled. And so we have to improve access to these other treatment modalities. We have, many clinicians, they get it, right? They know that opioid's probably not the best thing here and for this patient on this given day, but we're going to prescribe it again. I think there's education challenges. This is also part of the fragmented health information environment we live in, and these comments about mental health and substance abuse treatment data getting in it. And there are real concerns about privacy, and I don't want to have to be the one to solve that problem of what we can and can't release. But the more we can put data together from lots of different sources to help understand who's at risk, who's going to respond to what treatments, and it's not going to be an easy button. It's not going to be a perfect algorithm for all these challenges. But the more we can put data together, like the Management Performance Hub is talking about doing, like other entities in Indiana has done with Health Information Exchange, we can get a better picture of what a patient's history is, what they've done, what they haven't done in their treatment, and that's going to help the provider get them to the best care they can.
Thank you. I think we have time for one more question.
I was wondering, it seemed like the conversation's talking about all these different opioid options, and I was wondering about if Dr. Ray had seen any research about states that have passed medical marijuana and how overdoses might change, or any research?
Yeah, I mean, there was a fairly popular study in the American Journal of Public Health in Colorado showing that as marijuana was legalized there, that there were decreases it was overdoses. I mean, I don't think it's a magic bullet at all, and I don't think it's a solution. I think it could reduce some of the problems we're having, and that's one of these things that's going to need a lot more research. So we did a study here where we linked up all these individuals that got naloxone from EMS, like 5,000 folks over the past 6 years, and we looked to see how many of them went on to die. And it was about 10% went on to die, post having been resuscitated from naloxone. Of those individuals who did go on to die, 2/3 were over the age of 65. They're older adults that were getting resuscitated by naloxone, and they're probably the reason that they overdosed. One of the reasons could be that they were misusing prescription opiates. With a drug like marijuana, you might not even have that problem, right? Because you're not going to be able to overdose in the same way. So again, I don't think it's this be-all, end-all solution, but if you could think about prescribing medical marijuana to older adults that are coming out of post-surgery or have some pain, it could reduce the number of non-fatal and potentially fatal overdoses.
Anyone else?
I was hoping the marijuana question wouldn't come up. It's anecdotal, and I certainly have a lot of patients come to me saying, what do you think about medical marijuana, right? And I'm going to sort of waffle on the question in that, one, I think cannabinoids will have clearly an important role in pain management and multiple other things. As a medicinal agent, the science is trying to catch up. Okay, so we know that they will have these benefits. On the other hand, I argue that, association isn't causation. So a lot of people will say, well, our state has legalized medical marijuana, we have less opioids. That's association, okay? And so I think the science has to catch up with us. And the other thing, as a physician, if it's a medical treatment, I want it to look like a medical treatment, which means it goes through some process, and I know what the dose is and so forth. So I think we're in a grand experiment right now, and I'm hoping that the evidence catches up pretty quick and the science catches up, and that's one more tool available for me to treat chronic pain. But I'm in a bit of a quandary right now.